Right, so welcome everybody. It is great to see so many people. This is the largest group that we've had for one of our HIT Fests, so it's exciting. I'm confident that you will go home having learned some more about the registry. Hopefully you'll be inspired to go away and look at how you can improve your care for your patients who break their hip. And it's nice to be able to network and share learnings from each other. I'd like to make some very special welcomes today. So firstly to Carolyn Cooper, who's hiding in the audience there with her pink scarf on. So Carolyn is the aged care commissioner, who's recently started in that role. And it's great for her to come and learn about hip fracture registry. I'd like to welcome Andrea Pettit, who's sitting in the back there, I think, somewhere. So Andrea is the Chief Executive of the New Zealand Orthopaedic Association, so they're a key stakeholder in the registry. I'd like to welcome members of the New Zealand Implementation Committee, including Roger Harris right at the back, who's one of our co-chairs. And a very special welcome to our sole Australian, Jamie, at the front here. Jamie, you may have had emails from her, but Jamie is the coordinator in Australia. And she's been ultra busy recently putting the new report together, and we'll have a copy of the printed report for each site, so that's pretty exciting. Jamie's having a well-earned little mini break in Wellington, having recovered from all of that. So today our focus is on that part of the patient journey from rehab to home. Those of you who've been to a number of these HIT Fests know that we started looking at what happens from patient breaking their hip to having it fixed. Last year we focused on what happens once you've had your operation to being ready to go to rehab, so looking at those post-operative areas. So today we've come to that area of what happens in rehabilitation and people going out into the community. And it's great that today we've got quite a few of you who work in rehabilitation. So I'm going to set the scene with what does the data tell us, what do we know from the registry, and some other bits of data that I have. So this is one of the first slides that you'll see from the report. So to orientate you there, the top are the first five years of New Zealand data, starting back in 2017 and coming to our most recent report. And then down the bottom is individual hospitals. So you'll have to have pretty good vision to see where yours is, but this information will be available on the website and in the printed report. But what this shows is that 53% of people transfer from inpatient, so an acute orthopaedic ward, through to rehabilitation. And that's been pretty stable over the whole time we've been doing this. What happens to people who live in residential care? Do they get the opportunity to go to rehabilitation? And 35% of people last year did that. We were a bit worried last year. You can see that there was a decline in numbers, but that's picked up again. But you can also see that there's quite a range of, there's quite a lot of variability across the country, and that's something for us to think about. I have put Australia's data in there. I've only added Australia and we're doing better than them. So the rates in Australia of going to rehab from care is low and it's dropped a lot. Now we don't know the reason for that, and that needs to be looked at a bit more. I mean, it might be due to other models of care, but it is something that's strikingly different. So thank you to those who filled out a survey monkey prior to this, because I was keen to get an idea across the country about what services are doing. So we asked, do you routinely offer rehabilitation to people from rest home care? And you can see half of the sites do. There are a few that it depends. And the odd site that doesn't, which is a question in itself. Moving to hospital level care, the picture does change, and you could argue there's good reasons potentially for that, but most hospitals aren't providing rehab if you're in hospital level care, certainly not routinely. What happens if you have cognitive impairment and you live at home? Is that a barrier to getting to rehabilitation? So in New Zealand, 3/4 of patients did come to rehab, but it makes you wonder about what happens to those other 25%. These people have been living at home, albeit with cognitive impairment, and again, quite a variation across the country. So we do know that cognitive impairment can impact how well you do in rehabilitation, but the research is pretty limited and the results are mixed. And what it really means is that therapists and nurses here know that it just means taking a slightly different individualised approach to those patients. So are we offering rehab to people with dementia, whether they live at home or in care? Pleasingly, most of the time we are. So that's good, at least in New Zealand. So what happens when you come to rehabilitation? The registry doesn't collect any information really about what happens. All I can give you is how long people spend in hospital. So this is the acute length of stay. So the median number is 6 days, people staying in an acute hospital. And in terms of the total length of stay, that ranges anywhere between about 10 days and 20 days. So people are spending quite a long time in hospital, and most of that is in a rehabilitation setting. So what happens when people come to rehabilitation? 3 years ago at Burwood, we ran a project called Rethinking Rehabilitation. And as part of that, we did some patient follows. So we had data collectors essentially sitting with or near a patient from 8 till 3 with an iPad and collecting data on what they were doing. It showed that half of the time the patient was by themselves, and I'll come to that in a minute. Quarter of the time they were having clinical interactions with nurses, doctors, being seen on the ward round. Quarter of the time they were in therapy. It won't surprise you to know that for that half of the time of that they were doing nothing. So they were sitting there doing absolutely nothing. Not really what you want in a rehab setting. So yes, some of the time they were having meals, some of the time they were having a scheduled rest or sleep, but we were really keen to do something about this red bar. My main aim of this project was to have people spending less time sitting in their bedrooms, which is effectively what happens, and looking at how could we provide people with more meaningful activity outside their therapy sessions, which, you know, is a snapshot in the day. And how could we use social spaces? We're very lucky at Burwood with our relatively still new facility, but we weren't really optimising the use of that. And we had a really workforce sitting there in terms of volunteers. We had a waiting list of volunteers to come and help. And so we came up with some really kind of key metrics that those of you working here at Geriatrician won't be surprised to hear. That's similar things that many of these projects do. But we were very clear that we would have all our patients sitting up for all of their meals, including breakfast, unless they were dying or very unwell. We've since audited that, and we had quite high compliance with that. We wanted to be offering our patients the opportunity to walk at least 3 times a day, and that was outside of trips to the toilet. We haven't audited that since. It's quite labour intensive to do that. But I've been on a ward in a weekend and I've heard the nurse say to the patient, come on, we're up for our, we need to take you for your second walk of the day. We do have on the patient's wards a room with a place to tick your how many walks you've done. And one ward in the initial phase is patients got a chocolate fish at the end of the week. They've gone 3 walks every day. And in terms of social spaces, we've recently been very lucky to set up with some Ministry of Health funding co-fi companions. So these are volunteers who come in and spend time with the patient. And I haven't put up one of the pictures which is about getting outside in the sun, because that's what people really like to do, and the volunteers have been able to do that. FIN is, or your level of function, the lower your discharge FIN is, but importantly, you can see, you can see along this table, this line here, that apart from the extremely frail, frailty wasn't a predictor of absolute gain. So if you're frail, yes, it might take longer, but you still get the same amount of gain in rehabilitation. It just takes a little bit longer. This looks at, so the top line looks at were people discharged to their usual domicile, and even the extremely frail patients, half of those went back to where they came from. And in terms of return to pre-fracture mobility at discharge, that was about 30%, and improved to about 40% across the board at 120 days. So being frail shouldn't stop you coming to rehabilitation. Moving on to that transition into the community, I'm hoping most of you at least have seen this hip fracture guide that was released about a year ago. It's something that's dear to our consumers' hearts, and they're going to be talking to us shortly. So we know that this is relatively new. We know that trying to embed this into a system, a complex system, can be difficult. So we asked, how often are you giving these to your patients? And you can see there's a spread, and I can see some of you murmuring and maybe wondering what you actually do in your service. So this is something that we, and particularly the consumers, would like a bit more focus on. This was developed by, in conjunction with the consumers. If you want more information, we can let you know, but it's on the HQSC website and you can print it off. Because as you can see, some sites aren't using it. All right, what happens when patients leave rehabilitation? Again, we don't have a lot of data from the registry. We know where people end up, and we know what their mobility is like, and we know whether they get onto bone protection medication. So we took the opportunity to ask you which community options are you referring your patients to. So it's quite a range, and there's quite a lot happening, at least it's being referred. And later in the morning we'll hear from Jessie Snowden, who's who works in the community. She'll be able to give us her perspective. So the top line is the ACC Training for Independence program. The second is other ACC funded services. The yellow is early supported discharge programs. The blue is other DHB hospital funded community follow-up. Falls prevention, community exercise program is the orange, and a falls prevention program in the blue. We also asked the patients in your service regularly followed up, and that happened in about half of cases. I can tell you in Christchurch there really isn't the capacity to follow patients up. And if they were seen by an orthopaedic surgeon, which there's a lot of pretty topical at the moment, isn't it, about who else might be able to provide that? Does that need to be a surgeon? Could that be a nurse or a therapist or another member of the team? So despite offering lots of people rehabilitation, people still aren't returning to their pre-fracture mobility at 120 days. So it's about 50%. Our numbers last year just looked a bit lower, but you'll notice to the right we've got an increasing number of not knows. So I think that explains that drop. But 80% of people return to where they came from. So I think it's a pretty good outcome. So, like anything about data, actually it often just raises more questions than answers. So some of the things that I've been thinking about is how can we improve mobility outcomes? As a hospital-based clinician, I really don't have a lot of understanding of what happens in residential care, whether that's permanent or interim. What would be the ideal rehabilitation in the community? If we could idealistically, blue sky thinking, what would be the best for our patients? And really importantly, what do the consumers want and need? That's a deliberate segue into listening to our talk, hearing from our consumers. We'll have some room at the end for comments and questions. I'd like to invite Narangi and Caroline up. Narangi and I are going to start, and then Caroline's going to hold the floor as well. So Caroline and Hurring sit on our implementation committee. They've been a very valuable addition. Nothing beats hearing from the patient's voice. So I'm hoping that you'll enjoy this session.